Today we're going to talk about tobacco cessation and then about lung nodule management. So to introduce and firstly, important to recognize is that what we are looking at is about tobacco. So tobacco comes obviously from plant and it can be given in many different forms. When we think about cigarettes, that is the most common form of tobacco consumption. It can also come in forms of shapes of cigars. People can also use a smokeless product like chewing, sniffing, or snuffing the tobacco leaves. Or in certain culture, they may use a water pipe system to actually inhale the vapor coming from the tobacco. The issue that we have is that in the tobacco, there's no safe form of how we can consume it. It contains lots of different chemicals, and many of them are carcinogens that can lead on to different types of cancer, in which lung cancer is the most commonest form because of the inhalational route. In Australia, like many Western civilization countries that we're seeing, the rate of smoking is decreasing over time. In Australia, the success is because of successive public health measures, such as the tobacco tax, which limits and restrict the access of tobacco and cigarettes to our populations. However, over the last 5 to 10 years, what we are now noticing is there's a significant rise in the use of electronic. Seeing in here is that over the years from 2001 to 2022 on the left side, the amount of cigarette or tobacco consumption in Australia has dropped from about 24% to about 11% in the population. However, looking at electronic cigarette or vaping on the right-hand side, you can see it go up from about 11% now up to even 20%, especially in those who are the youngest in our populace. In particular usage, we're concerned about are those who are between the age of 14 up to about 30, where there's a high consumption over time of change of using e-cigarettes, where many of them are actually lifelong non-smokers in the past. If you look at that data, interestingly, those who have got a much more higher economic social background tend to smoke electronic cigarettes compared to those who are actually of the lower socio-economic background that tends to smoke tobacco or smoking cigarettes. So what is the harm of tobacco smoking to us? So this has, as I said, have about 7,000 type of chemicals when we smoke a cigarette. And that can, many of those have carcinogen that affects many different organs, both in a smoker and also in those who have secondhand exposure, be that children or adult, where it can affect their respiratory systems, their cardiac systems, and also we have seen infants that die from sudden infant death syndrome because of the secondhand exposure. The major risk for smoking is going to be on cancer, cardiovascular, and respiratory diseases. This is a very nice article published by in the European Journal of Cardiology that's demonstrated the health risk associated with smoking. In the red color is traditional tobacco. In the blue color is our water pipe. And in the green color is electronic cigarettes or vaping using nicotine. Because of the lack of extensive evidence or data yet on electronic cigarettes, some of the data there are still not quite present, for example, lung cancer risk. But you can see across the board, regardless of what form we use to inhale nicotine-containing tobacco, there is significant cardiovascular, cerebrovascular, and atherosclerotic effect on our heart and our blood vessels, and causing significant increase in inflammation of the vasculature. So the effect of the nicotine on the body, nicotine is the addictive substance of the tobacco. What it does is that when you got inhaled it or consumed it, and it go absorbed through the mucosa into our bloodstream, it goes to the brain very rapidly, especially when you inhale through the airway. And once it gets into the brain, it activates nicotinic receptor, and that leads on to an award or rewarding behavior, euphoria, and happiness, which then drives and lead on to future craving for nicotine. And these receptors in the brain, unfortunately, once they're activated, will forever be able to activate again, which makes smoking cessation very, very difficult and challenging for many of our patients, as it's highly addictive. So nicotine addiction, as I hinted before here, is difficult. Once you get a smoking cues, it could be stress, it could be environmental cause. It leads on to this craving that leads on to the smoking, then a spike of nicotine in our circulation, activating the receptor, and it goes through this whole circle and cycle again. And commonly, when you withdraw someone from nicotine, much like withdrawal from alcohol and other addictive substances, the patients go through withdrawal symptoms, which can coincide with pharmacotherapy that we use to target smoking cessation, leading on to perception often of side effects, whereas actually majority of these are withdrawal symptoms from the nicotine. So in terms of smoking cessation, it is fundamental and we should be all practicing in all of us. We're now looking at a very simple 3A approach, replacing the old 5A approach, which makes it very easy for every single practitioner and clinician from our allied health nursing side, pharmacists, as well as us doctors who can easily practice it. So what is the 3A? It is very simply ask, understand whether or not the patient ever smoked or is a current smoker, advise about the impact and health risk associated with smoking, and act, which is really looking at either we can commence pharmacotherapy and non-pharmacotherapy, or link them in with suitable professional who can help them and provide them with both pharmacological and non-pharmacological technique to help with smoking cessation. Well, a combination of both pharmacotherapy and non-pharmacotherapy behavioral therapies have been shown in evidence to be the most successful form to help with smoking cessation. So behavioral is very simply about counseling. This can often be done either face-to-face or after the recent COVID pandemic, online, by short SMS messages, or even over the telephone. In Australia, many of these can be done via our Quit line, which is a national telephone services to offer counseling in all types of languages for the patient to use. In other countries like the UK, they have specific smoking cessation centers or quit centers that have got staff members that can help provide this help to our patients. So when we look at behavioral counseling, the most important thing is to understand and the impact and the reasoning perhaps or the barrier for the patient. And also look at what motivates the patient to smoke or to quit, and to look at strategy to help them to avoid situation which can lead back onto the craving that they experience. So the approach that we usually look at will be avoid the environment or changing the social cues, or if they cannot, escape. So it could be that they're in a situation where there are social events that all the other people are smoking. They may have to escape and leave the event in order to reduce the craving that they experience. There are other different types of coping strategy that we can lead on our patients, all the way from distraction strategy, such as cognitively, oral strategy. So rather than smoking? Can they looking at, using lozenges or gums, other things to help? Looking at erection of no smoking zones, which are around many of our public places, and other types of behavioral distraction, such as if they are feeling that they want to smoke, can they do other things to distract themselves, taking up a craft, doing other chores, anything else, so that they do not look at using or going back to the habit. But smoking cessation cannot work purely just by behavioral therapy, behavioral strategy without pharmacotherapy. Pharmacotherapy is important to try to suppresses the nicotine receptor and the link that nicotine has on the receptor, and therefore to try to stop that urge that the patient experience. The most key question when we're looking at pharmacotherapy should be to our patient is about how much they rely or how addicted that they are to the tobacco. So for example, the good question that we usually ask is, from the time you wake up out of bed, when is your first cigarette? If it is less than 30 minutes, they have a very high dependency. Also, how many do they smoke per day? Again, more than 10 or less than 10? And what in the past they experience when they try to quit? The urges, withdrawal symptoms, etc. Then picking which agent to use would depending on the patient's also health and the background, allergy, etc. If you look at the bottom table there, that shows highlight even with the best medication, which is varenicline with behavioral support, or dual agent NRT, so not just a long acting, but a long acting and a short acting, such as a patch and gum spray or lozenges, together with behavioral therapy, they can achieve up to about 30% of success in 12 months abstinence. So that just means that 3 out of 10 would be successful using that strategy over 12 months, which still leaves 7 out of 10 which will still fail. Hence, it is important to also tell a patient that if they are not successful in their attempts to quit, don't despair, because that is very common because of how addicted and addictive nicotine are, and that successive quit attempt usually does help improve the overall success rate. And for those patients who said to me, can I just go cold turkey, not use anything at all, just stop abruptly? Unassisted success rate is usually about 3%, much, much more lower than combination of behavioral therapy support together with pharmacotherapy. So if you look at nicotine replacement therapy, this is the most common form. So this works by replacing the nicotine and therefore stop the urge. You can see in here, in a traditional cigarette, in the pink color, it is very rapid rise in the plasma nicotine level once you inhaled because of the exposure to a huge amount of nicotine when they inhale the cigarette tobacco. So the only way that a short-acting rapid delivery system that can mimic cigarette is using a sublingual spray. If you compare that to gum, lozenges, or tablet, or even a patch, the delivery is a lot more slower and also lower peak level. Hence, for maintenance, a patch is great because they're long-acting, but they're often not adequate for many of our patients who does get those urges. Hence, you need both a long-acting like a patch together with a short-acting like a spray to help, with our smoking cessation effort. The usual duration would be less than 12 months. The dosage would depending on how many they smoke per day, rather than 10 or more or 10 or less. And even in patients who have got a myocardial event, like a heart attack, it is still safe to use nicotine replacement rather than cold turkey. There has been good evidence to show even in the acute cardiac space that it's safe to discuss and commence pharmacotherapy. The next first-line treatment that we use for pharmacotherapy is varenicline. So this is a partial agonist on the nicotinic receptor. Therefore, by competing against it, it displaces the nicotine from the smoking and therefore again reduces that urge. It is very similar in terms of outcome compared to dual agent NRT. It is an oral tablet. The duration of use usually is 3 months up to 6 months, but you can repeat it again after 12 months if a person relapse. The most common side effects tends to be gastrointestinal. Sometimes it can be confused with the withdrawal symptoms from the patient. There was concern initially when it was released that they may increase some psychiatric effect on the patient, but subsequent large study comparing varenicline to other agents such as nicotine, bupropion in both patients with and without mental health disorder did not find any significant increase, and therefore and that's from the EAGLE study published in 2014, and therefore it can be safe to use in those circumstances, though it is important to counsel the patient and the family to watch out for symptoms such as vivid dreams or mental disturbances that they experience over time. It is a dose escalation where you start off with just 0.5 milligram on the first 3 days, then from day 4 to day 7, go to 0.5 milligram twice daily, then 1 milligram twice daily after 7 days on going to 3 months or 6 months. If the person has very significant GI side effects, nausea, vomiting, that doesn't stop after day 7, then we can look at dose reduction back to 0.1 milligram a day, half the dose, though that may mean slightly reduced efficacy of using the medication. Next one that we are looking at is bupropion. This is a dopamine antagonist. Not entirely sure how it works in smoking cessation, as it was firstly discovered or developed for the use of depression. But what it does and can do, it does have a good benefit in patients, especially those who have got cardiac diseases or COPD, to help with the smoking cessation at all. The success is not as good as varenicline or dual agent NRT. It is important to recognize that a major side effect is epilepsy or seizures. So it is very important that in patients with those history, they really should not be on to bupropion. And it is important otherwise that they should reduce their consumption of alcohol as it may compete in the liver for metabolism. There are 2 other second-line pharmacotherapy that we'll recommend for patients to use if they failed those first-line pharmacotherapy. Unfortunately, for both of these, they are not registered in Australia to be used. So one of them is nortriptyline, which is an antidepressant. It is licensed in New Zealand, but not in Australia. The other one is cytosine. Like varenicline, it is a partial agonist, but it is a herbal extract, very commonly used in Eastern Europe and is very, very cheap. It is found that by using the cytosine, you can get outcomes not as good as varenicline or dual agent NRT, and it is probably similar to one single agent, NRT by itself. So that's why it can be used as a second line, though for Australian consumers, they will probably have to look at buying it online. There's currently TGA application to consider it for to register it to use in Australia. People then often ask, what about e-cigarette or nicotine vaping product? As there are evidences or discussion online that people say, well, I can use it to help reduces my tobacco nicotine consumption. So whilst electronic cigarettes containing nicotine or electronic cigarettes without nicotine both are not safe products, it is important to recognize no form of any type of any tobacco consuming product are safe. There are increasing evidence coming from UK and other countries, and the latest Cochrane review does show that if you're looking at using e-cigarette containing nicotine, there is a possibility and that it can help in the general population to quit their smoking tobacco habit or reduces their consumption. However, this is not as good as the W agent NRT. This is not as good as varenicline, and certainly it is not the risk-free approach that we can have. There are also evidence that if you combine the electronic cigarette with a single agent NRT, you may perhaps get a slightly better cessation outcome, but that still is not as good as our first-line pharmacotherapy, whilst there is a slight increase in adverse event, which mostly relates to the airway irritation that often found in electronic cigarettes in the acute setting. But also importantly, we still are not sure yet of long-term health effect that e-cigarette can have on the body because we don't have enough longitudinal data. But for those patients who are either using it as a smoking cessation tool, or you have got patients who are not tobacco smokers but are on electronic cigarette, how do we looking at reducing and helping them to quit? That becomes a bit of more of a challenge as the evidence is still lacking in that space. The University of Wollongong has published some work to help the federal government. And in Australia, as we know nowadays for electronic cigarettes, it's meant to go to the pharmacist where you can get dispensed a prescribed product of electronic cigarette. There are two types of electronic cigarette product out there, either open system, which means that you can add and replenish the chamber, or a closed system, which are disposable. In this circumstance, usually we recommend that using a closed system will be better because that does not allow potential tampering with the electronic cigarette content. And that also allows very clear calculation of the nicotine salt that are present in the electronic cigarette to help the reducing and the dependency and therefore dose reduction approach to the electronic cigarettes over time. So you can see in the blue color there are some suggested nicotine vaping product dosages to help guide a smoker to how to slowly reduces their tobacco consumption and then how to then slowly also reduces back from the electronic cigarettes over time. So in terms of vaping cessation, especially in our young children, very similar to smoking cessation, the behavioral support is vitally important. But the differences that we have is that they are a slightly different group of cohorts. We're dealing with usually much more younger patients, have very different motivation and different environmental triggers, tends to be usually more often social or family context of why they use electronic cigarette. And it's very important in this situation that we need to be clear about the danger of using vaping product, it's very clear that we need to look at their motivation to help understand how best to engage with them. And there are lots of marketing strategy coming out from the health department, such as using online video, social media campaign, etc., to help. But it would also suspected to be a multi-approach, as many of the current electronic cigarette product that we have or vaping product on the market, both black market and on the real legal market, have got contents in them that is very difficult to gauge the purity. And there are products that has been published before that shows that they are set forth to have no nicotine, but in fact there are nicotine contained. And therefore, the danger that many of the users may have in using it. So let's skip to the lung nodule, second part of the talk, which is vitally important for us. As explained, lung nodules are increasingly found all over the world. Well, why is that the case? We suspected that that's partly because of increasing use of CT scan, especially low radiation dose CT and CT that can do very thin slides. And therefore, with improving technology, picking up sub-centimeter nodules or spots in the lungs are becoming increasingly common. There are also other countries in the world that have already established or commenced lung cancer screening program, and therefore also them picking up nodules much more earlier, as many of these patients are usually asymptomatic at that stage. In general population, we suspect up to about 13 to 15% will have a nodule. But majority of these are benign. They are not cancerous or malignant. It is very important when you look at data published out there about lung nodule, you have to look at which center are publishing their data and what is the likelihood of cancer in that population. If you look at publication in centers that are dealing mostly in cancer space from America or Europe, the likelihood of cancer pre-test is already high. So that is why their malignant nodule is a lot more higher than those who are general population publication in across the population mean, which is why there is this variation of prevalence of malignancy in lung nodules in the literature. And that's something that we just have to be mindful of. When we look at the diagnosis of workup of nodule, we need to ask ourselves firstly, what is the risk that this could be malignant? And we'll talk about that in a second. What do we think about the next step of management? What is the risk from the patient? And then we look at the actual nodule itself in terms of the size, the shape, material inside, what does it appear like? The three main type of nodule that we usually classified are ground glass in picture A, a subsolid, which is both ground glass and a solid in a material within, so in B, or a pure solid nodule, which is in picture C. And that is important because that helps us to look at the risk assessment. In those patients who got low risk, routine CT surveillance is probably adequate. Whereas those who got moderate to high risk feature, you may want to be more aggressive, either looking at more imaging testing, such as FDG PET scan or biopsy, or even straight to surgery if it's highly suspicious. There are risk prediction models that are often used nowadays in specialized clinics that are usually consisting of lung specialists, radiologists, oncologists, surgeons to discuss nodules. In these centers and MDT setting, we usually would look at different type of risk prediction model. So if you look at the blue table, you can see that in the Mayo Clinic model, compared to the Brook University model and the Cleveland Clinic model, the percentage of nodule that were used to calculate those risk analysis is vastly different. Which is why if you got a patient who has a general population, we would usually want to look at a Brock University model, which is a much more general population comparison, where only about 6% of the nodules were actually malignant. Whereas if you are a center that specializes in cancer, that means that most of the patients coming to us, we suspect will have cancer or they're high risk. You will probably looking at using the Mayo or the Cleveland Clinic model, which is a more higher risk. And you can see it come a very different outcome in terms of risk analysis and the approach. But in terms of likelihood ratio for malignancy in a single pulmonary nodule, if you look at the TASTE table, the important parameters we always look at is age. The older the patient, the likelihood of it turning malignancy is higher. Second is the size of the nodule. More than 5 centimeter, the bigger it is, the risk starts going up. But you can see there, anything up above 2 centimeter, the risk starts to exponentially go up. Smokers, of course, is higher risk compared to lifelong non-smokers. Higher number of PEG years, again, increases the risk. And the longer you have quit smoking, the risk drops with time. Which is why the Australian lung cancer screening, as you discussed before, targeting mainly at those who are 50 to 70, who are either current smoking or who have quit within the last 10 years and who have more than 30 PEG year history, to try to pick up those who are the highest risk of lung cancer or malignancy in those nodules. But beyond that, there are also further characteristics of the nodule itself, besides the size, that are concerning. The edge, if it is very ill-defined, if it looks spiculated, they are more concerning than a very rounded, defined edge. Furthermore, if it is calcified, that suggests chronicity, again, slightly lower risk compared to a non-calcified nodule. If it is growing, especially in a three-dimensional volume size, growing bigger over successive surveillance, that is concerning. The location, most lung cancer picked up in the lung cancer screening trial over the world tends to be in the upper lobes, right more than the left. So again, if they're in upper lobes positioned, more concerning. And then we talked about before about age and then smoking history. And depending on that, we come up with this kind of recommendation in terms of whether or not you may look at just surveillance with low dose CT. Low dose CT means low radiation dose CT to reduce its radiation exposure to our patients, while they are usually thin slides less than 1 millimeter. So they give us the best opportunity to look for these changes. Or we look at more activity scans such as FDG, PET scan, or even biopsy via CT, surgery, or endoscopic means. So one single incidental lung nodule, those who got low risk, depending on the size, there is some recommendation in terms of the frequency of the low dose CT. But if it increase in size, then of course you would then activate and look at the next step in terms of further defining the risk by either biopsy or FDG PET. If there are multiple nodules, then you'll probably want to determine this on the largest nodule, especially if it is solid, or if it is one that is growing and changing. So those are worrying features of it. In terms of subsolid nodule now, so they're solid, they are not completely solid, but they have got some ground glass feature in there. Whether they're part solid or pure ground glass may alter how you approach it. Increasingly, a lot of those ground glass nodule or subsolid nodule has been found to actually could be carcinoma in situ, which is lipidic carcinoma in situ, early forms of lung cancer. So in many of these circumstances, we extend the surveillance usually to make sure that it doesn't grow over time because they could be very slow growing. And whilst there are studies usually suggesting you can stop surveillance after 5 years, in reality, I think the data is still lacking in terms of whether you would really truly stop in 5 years if it doesn't grow, because many of these nodules may changes and grow over time. So I think we should need to watch this space as we get more and more understanding of what this kind of ground glass carcinoma in situ type tumor does to, and this recommendation may change with time. So now we comes to then this kind of assessment that they can be online, which you can type in your patient's detail, like the age and the gender, their smoking history, etc. And you'll come up with kind of this risk analysis and recommendation of what to do. So this is the USA lung cancer assessment screening. There are other types that are online around, but I'll certainly recommend that in those who are interested, you can look at some of these calculation risk prediction models. Just a little bit of talk about diagnostic approach. As part of the lung cancer screening, the most important next step, if you do have suspicion lung cancer, of course, is to send it to the local team that you work with that are in the lung cancer MDT, which is multidisciplinary team setting. Why is that important? Is that we want to maximize and ensure that your patient gets seen in either rapid access clinic that are often now as has been established, or to specialists who are in the space, who works with the space and can rapidly work up and assess so we do not delay the patient's next step. Because to do diagnostic approach, we can do it via CT, which on the left side can see through the skin, or increasingly so via bronchoscopic means on the right, which is navigational bronchoscopy to biopsy these nodules. And so, the people who are in the space who works with your lung cancer meeting locally, and you can easily find those usually on your primary health network web pages, or Cancer Link that would tell you which are specialists in those field, respiratory specialists in those field, will probably be the first step who can then help the patient then to quickly navigate through the processes. But everywhere the local to you, I'm sure that you can find that who are the important people that you refer to get this step going. So in summary, it is when we talk about nodule, we talk about nodule that's smaller, usually less than 30 millimeter or 3 centimeter. With more than 5, they're usually called masses. It is important to note the location, the features, the size, number, and also to look at the patient's risk factor, and then we look at the analysis for risk. It's important to use a low-dose CT scan to help us clarify, and that in fact will be usually the surveillance imaging of modality of choice over time. And then, if you find they're suspicious, refer them rapidly to your local team that are in this space. In the last few minutes, I just want to quickly update everyone about staging. Cao has very kindly before demonstrated some data about life expectancy, which we look at is 5-year survival. The International Association of Lung Cancer Study in the last few years have updated, and in the latest 9th edition is basing on lots of longitudinal data of patients to try to ascertain to the TNM staging system to give us a best approaches about risk for patients, survival features, and then to help guide the treating team in terms of developing different kind of modality to treat. So in the 8th edition, which on the left, now changing to the 9th edition, you can see that with increasing understanding and studies of lung cancer the last decade or so, the increasing split of stages to starting to define whether the lymph node station, which is very important for local or spread, into multi-station or single station. And that splitting of the stage you can see in the N2. And furthermore, even for metastatic, that means beyond the original site, starting to tear out whether the pleura or the pericardial is involved, whether it gone to the other opposite side of the lung, gone just one single lesion outside the lung, or multiple lesion within one organ or different organ to look at the stages in below. Which is why you may see that in the report of the biopsy or the cancer MDT, increasingly the complexity in the discussion, and that would define from the MDT discussion about which modality treatment approach. So lung cancer treatment has changed significantly over the years. There are now much more better treatment from surgery to radiation, to chemotherapy, to immunotherapy, to targeted therapy, many different forms. And which line to use this would always many often depending on this discussion of our patient as there's such a big, large heterogeneous group within. And most accurate, this is the last slide, to determine survival is always pathological staging. That means actually having tissue rather than basing on radiology so that we can truly calculate the stage. And you can see nowadays, if you look at using the 9th edition, in those patients who are truly stage 1A, their 5-year survival is as high as 94% if they're very early stage and very small. And in the 7th edition back in 1999, you can see that whole big group is lumped as one, which is a very significant different prognostic feature of 73% overall. Whereas nowadays with in different way of, and the differences between those addition is actually there are a lot of proportion increases of Asian cases being reported, which helps further define the features. And you can see that's why nowadays that staging is so important. But even if someone has got stage 3 disease, which in the past we would have said they have got quite poor prognosis of less than 25%, you can see in the 7th edition. Nowadays, they can go as high as 50%. So that's really doubled. So that is why it is vitally important that we stage accurately, which is the role in our specialists that involved in the lung cancer MDT, and that is our job to do in various different ways to help guide our patients' management, help them become long-term survivor. So thank you. This is my end of my talk.